I'm Daniel Levine, and this is the Bio Report. Sepsis remains one of medicine's most intractable and costly problems, arising when an infection triggers a runaway immune response that damages organs long after a pathogen is controlled. It accounts for an estimated $53 billion in Medicare spending alone, yet more than 100 drug trials have failed to yield a single approved drug that directly treats the underlying immune dysfunction. Inflammatix, which grew out of work at Stanford University, has developed a point-of-care blood test to determine whether an infection is bacterial or viral, as well as the severity of the patient's immune response to optimize treatment. We spoke to Tim Sweeney, CEO of Inflammatix, about the company's TriVerity test for sepsis, how it works, and how it's used in an ER setting to determine who needs antibiotics, ICU-level care, or a broader diagnostic workup. Tim, thanks for joining us.
Thanks, Dan, for the invite. Much appreciated.
We're going to talk about sepsis, Inflammatix, and its point-of-care test to diagnose and stratify patients with these potentially deadly blood infections. Let's start with sepsis, though. What is it?
Well, actually, Dan, the way you introduced it is perfect. So many people think of sepsis as a blood infection. And honestly, if there's one takeaway from today's interview, maybe it's that that's kind of an older way of thinking about sepsis as a problem. We used to sort of say things like blood poisoning, to describe someone with a severe infection. But we've learned over time that people with sepsis actually, maybe less than half of the time, actually have an infection in the bloodstream. It's in the modern definition, we say sepsis is the combination of an infection anywhere in the body combined with a quote, dysregulated host response. Now, if you can define dysregulated host response, you'll be better than the entire sepsis community because no one has actually ever been able to define that. But what it really means is that essentially in sepsis, there's been an infection, the immune system has been activated, and rather than kind of a feedback mechanism of, great, we fought the infection, now time for the inflammation to subside, you've entered a feed-forward inflammation, where the inflammation is beginning to cause more inflammation and actually beginning to directly damage the body itself. And so in modern sepsis, most people get antibiotics, we stop the infection, but they still end up in the ICU for weeks. And it's because we really don't have a way to stop that underlying inflammation that's causing the problem.
How does it manifest itself and progress?
Well, everyone's had an infection, right? You've been sick, I've been sick, everyone's been sick. And you take something like maybe it's a splinter, right? You get a splinter and gosh, if you leave that splinter untreated, maybe it becomes a tiny little abscess. But maybe it was on your leg and you didn't see it, and that tiny little abscess starts to cause a regional infection, maybe what we call cellulitis, where now you've got a big area of skin that's red. And if that really goes untreated and it's big enough, and the sort of the burden on the body is high enough, now you begin to feel systemically ill, right? Now you have a fever, and your heart rate goes up, and if still left unchecked, you can end up in the emergency department or the ICU with a really bad infection and sepsis. And even when we fix that infection in your leg, you can still be sick for a long time. And so it's really a progression of any infection through its later stages. And one of the first things you'll ask is, well, how do we know who is predisposed to sepsis? The answer is we don't know. We still just don't know as a community why some people tip into sepsis and some people don't. And that's one of the reasons that early identification of who has an infection, whether it's bacterial, whether the person needs antibiotics, and how sick they're likely to be is such critical information to managing these patients correctly.
Well, how significant an unmet medical need does it represent, and how costly a problem is it to the healthcare system?
It it is easily the single biggest, I would argue, problem in the healthcare system. It is by far and away the number one most expensive diagnosis in Medicare. Last count was a couple years ago. CMS paid out $53 billion for sepsis diagnostics, for sepsis diagnoses, meaning people in the ICU with sepsis. It's also the single largest source of medical malpractice claims. So it's frequently misdiagnosed, um, and it precedes half of all hospital deaths. So it's a big problem, and it's not for lack of trying, that we're still here. It's people know it's a big problem. It's just been very stubborn to any kind of new solutions really making a difference in outcomes.
The real danger in sepsis is when it does involve an immune system dysfunction, as you were talking. This is something I didn't realize was underlying sepsis. Is this what's known as a cytokine storm? And
Yeah, well, yes and no. But nowadays, post CAR T, most people when they say cytokine storm mean that that very particular response to CAR T therapy kind of gone awry, where there's been a lysis and it's caused this massive inflammation. But to your point, that terminology actually started in sepsis. About 10 years ago, they ran some of the very first transcriptome-wide studies in sepsis, and so much was changing in the body's, transcriptome, meaning which genes are being turned on and off, that the authors at the time termed it a genomic storm. They said, we can't, so much is changing, we can't really interpret it, but there's clearly a genomic storm in sepsis. And actually, one of the things that really made our work possible at Stanford in the early days of trying to understand and get a handle on what is the inflammatory response in acute infections and sepsis and critical illness were some of those early papers where they had said, everything is changing. And we said, great. So now let's try to get specific and see, well, what are the changes specific to an infection, or what are the changes specific to needing to go to the ICU? What are the changes specific to sepsis versus not? All those things. So it's really been, very active area of scientific progression over the recent decade.
if you think about treating in an infection, you generally want to stop the infection and have agents that can counter that. But when you get that overactive immune response, you kind of want to do the opposite. You want to quiet the immune system. How does this complicate treating sepsis?
Well, maybe we can define kind of two separate problems, if you will. And I think this is more and more what the community of sepsis researchers seems to be focused on. When somebody comes in with sepsis today, somebody shows up in the emergency department with low blood pressure and a high heart rate and just obvious classic signs and symptoms of sepsis. We actually pretty much know what to do. We know how to resuscitate them. We know how to get them the appropriate antibiotics. Taking care of somebody in the initial phases of sepsis is pretty well understood. There's really two problems that the community faces. One, to your point, is great. We treated that patient with sepsis with antibiotics. We got them to the ICU, but they're still there. And that inflammatory response is still making them critically ill. How do we turn it off safely and effectively? And there's a whole bunch of research into immunomodulatory therapies to try to improve those patients. And we have some active research in that. But the other is somebody showed up in the emergency department and they're not septic, but that doesn't mean they're not sick. Somebody with a cough and a fever or a rash with tachycardia. You have to know which of those patients deserve antibiotics, which of those patients, maybe you need IV antibiotics and need to come into the hospital versus which are safe to treat at home. Which of these have a viral infection or something totally non-infectious underlying them? The whole point is we need to figure out who sort of move up the spectrum of illness and be picking out those patients that don't look that sick today, but could be very sick tomorrow if we don't treat them right. And so I think there's those two separate kind of, early diagnosis and then management of late complications. And I think they're both very important.
So if I'm diagnosed with pneumonia, a doctor is going to determine whether I have bacterial pneumonia or viral pneumonia before prescribing me a drug. How is sepsis typically diagnosed today?
Well, you actually bring up a great point. Let's say that you come in with a cough and a fever and you get diagnosed with a pneumonia, and a doctor's going to determine whether or not it's bacterial or viral pneumonia. Well, the bulk of that diagnosis is clinical gestalt, which is a really fancy way to say it's a guess, right? We don't really know in the vast majority of pneumonias whether or not it's bacterial or viral. If you run typical microbiology, meaning you're looking directly for bacteria from sputum or blood cultures or urine serologies or nasal swabs in a patient with pneumonia. So you run all of the microbiology we have. You will miss about 60% of bacterial pneumonias. They will just come back with no positive microbiology. And the reason for that is these infections are deep seated. You have some bacteria deep down and some air sac in the lung. There's no way to sample it. So we guess, and we treat a lot of patients with antibiotics that probably don't need them to be safe. And a smaller but more serious problem is we miss some people that do need pneumonia, that do need antibiotics today, but they don't get them. We ran a 1,200 patient study on this new product, TriVerity, where it was being run in the background to test it for accuracy. Since then, we've actually done some studies, where it's been implemented to improve care. But at the time, to get FDA clearance, we ran a big study on patients just like this, showing up in the emergency departments with, a cough and a fever. And one of the things we found was that 1 in 8 patients who were ultimately diagnosed with a bacterial infection, 1 in 8, left their initial emergency department visit without antibiotics. So it's actually surprisingly common to miss a bacterial infection on the first go because, again, we don't have definitive diagnostics, or at least maybe I should say we didn't. And that was one of the main problems we were trying to overcome in building TriVerity as Inflammatix's first test on market.
Well, so how is sepsis typically treated if I show up in an ER?
Well, there's 2 mainstays of treatment. One is the treatment for the infection, and the other is the treatment for the, sort of the illness severity. So how do you treat an infection? Well, you treat it with antibiotics and what we call source control, right? So source control is, of course, if you have a pneumonia, you just need antibiotics. But if you have an abscess, then you drain the abscess in addition, right? So one is just taking care of the infection with appropriate antibiotics. The other is to support the body through its inflammatory response. We give people fluids to prop up their blood pressure. We can, over time, if they're having organ dysfunction, we can breathe for them, right? With a breathing machine. We can oxygenate their blood for them. We can do the work of the kidneys, right? There's lots of fancy tools that we have in the ICU. None of those treat sepsis. All of them treat the sequela of sepsis. There are 0 approved therapies that actually treat the underlying immune response of sepsis. And that's one of the things we're trying to change.
So is there a problem with the protocols today for treating patients when they appear to have sepsis?
Is there a problem? Well, I think they've gotten better over time. It used to be that sepsis mortality hovered around maybe 40%, 30 or 40%. And that's since come down to maybe 20% with modern protocolized care where people get early antibiotics and they get resuscitated well. But it's still 20%, right? It's not 5%. And that's because, again, some people end up really sick in the ICU and they're, the inflammatory response is raging and we don't really have a way to turn it off. There's been over 100 drug trials in sepsis to turn off that inflammatory syndrome. And there have been no successes, 0. Every single attempt to kind of drug sepsis with an immunomodulatory therapy has failed to actually make a difference. Now, we think one of the reasons for that is that just like with cancer, there are different subtypes of critical illness and they deserve different therapies. So imagine for a minute you're a woman in the 1960s diagnosed with breast cancer. Well, what do you have? Do you have ER, PR, HER2 new breast cancer? No, you just have breast cancer in the 1960s, right? So every woman gets treated the same. They all get radical mastectomy and chemotherapy, and outcomes were really bad. But what changed over time was a better understanding of the molecular basis of the disease, right? We identified ER and PR status, and we got tamoxifen. Then we get HER2 new, and so we get Herceptin, and then there's Nanoprint and Oncotype on the I-SPY trials. And as we subdivide breast cancer into what's really a bunch of very similar types of cancers, each with a bespoke treatment, survival got much better. And that's really how things are today in the ICU. Someone shows up with sepsis, and in fact, there's probably a lot of different forms of underlying sort of molecular basis of sepsis, but we treat them all the same. And there's no single therapy that benefits everybody. And so we don't have any therapies at all. But if we could use immune profiling to identify subtypes of the disease, those different subtypes might be individually druggable. And in fact, we just published 2 papers in Nature Medicine looking specifically at this ability to subtype critical illness based on inflammatory profiles, and show that they are differentially responsive to certain immunomodulatory therapies. So I think that next era of critical care is something that we're really just right on the cusp of.
Well, let's talk about the TriVerity test system. This is Inflammatix's test system that was approved in January 2025. It's an AI-driven system. What exactly is it, and how does it work?
So thank you for the question. So the TriVerity test system was brought through FDA clearance in January. It's a new blood test for managing patients with a suspected infection and one vital sign abnormal who are presenting to the emergency department, again, with a suspected infection or suspected sepsis. Now, TriVerity represents really a new capability for the health system. For the first time, based on our immune profiling, within 30 minutes, we can tell who has a bacterial infection, separately who has a viral infection. And there are actually 2 separate scores with the test. So, for instance, a patient could score as a high bacterial, high viral case, as happens with some co-infections. Or maybe more importantly, could show as non-bacterial, non-viral. This is some other form of non-infectious inflammation. And then the test has a third score, that's our illness severity score, that basically reads out how likely someone is to need ICU level care from any cause over the coming week. And so you get these 3 scores. That's why it's called TriVerity, try for 3. And they can begin to provide a holistic picture of the patient. So for instance, somebody who comes in, let me put it this way, somebody did come in to one of our sites that's using the test relatively recently, and they had a low bacterial score, a low viral score, and a high illness severity score. So initially they were being worked up from pneumonia, but on seeing this was, non-bacterial, non-viral, but at very high risk of going to the ICU, the physicians broadened their workup and sent a heart attack marker, and it turned out the patient was having a heart attack. And so they got it in, very different care. But you could also imagine that we can very quickly spot bacterial infections that aren't otherwise, being picked up by currently available tests, and really, in the end, transforming the way we move patients through triage by providing a holistic picture of both diagnosis and prognosis right up front to the emergency medicine physician.
You've made the point that sepsis is not a single condition, but a condition with many different subtypes. Where are we in terms of efforts to classify the various subtypes?
Well, maybe before we go there, maybe it's helpful to sort of talk about the 2 ends of almost like a funnel, right? And it's worth just briefly reviewing some epidemiology. So there are maybe 140 million visits to the emergency department every year in the United States. And of those, there's maybe 30 or 40 million that are for some kind of suspected infection. People showing up with signs and symptoms that make it seem like an infection is likely, 30 or 40 million. Now, of that, there's maybe 1 or 2 million cases of sepsis per year. So sepsis is maybe 5% of that suspected infection population. And TriVerity is really meant on that big end of the funnel. Anybody with a suspected infection, we're hoping to just optimize, who does or doesn't need hospital care, whether or not they need antibiotics. Those are the kinds of tests and decisions that we want to be able to help with TriVerity. Now, your question was also, well, what about this subtyping of patients with sepsis? So now we're kind of going to the other end of the funnel, right? Of the maybe 2 million patients with sepsis, how can we figure out, is there a different profile or subtype of these patients? And in that, sicker group that's in the ICU where we're trying to figure out how to make them better, we've shown now that there's actually agreement among researchers about what those subtypes are. In fact, we can show that there are 4 subtypes of illness. For those of you that remember kind of your immunology, we have a lymphoid axis, B cells and T cells, and we have a myeloid axis like macrophages and neutrophils. And essentially, if you think about those two axes, lymphoid and myeloid, in a 2D grid, some people can be dysregulated on both, lymphoid and myeloid. Some people can be dysregulated on one axis or the other. And then some people are, frankly, dysregulated on neither axis. Even though they have sepsis, if we keep our hands off them, they'll probably get better on their own. So that makes up these 4 subgroups. It was there's a mnemonic for that presentation we called the high def system. And that consensus among researchers, again, was published about a month ago in Nature Medicine. And one of the things that we're really excited about is that we can produce really rapid tests on our test system that are able to actually very quickly put someone into one of those buckets. And, in the long run, obviously, it will still take things like regulatory review, et cetera, to get that through to actually help patients. But very clearly, the ability is there to tell, what subtype is a patient, and eventually, definitively, what treatment will they benefit from.
So do you expect the test to be able to just return result identifying the subtype, or is that something that a physician would have to take the scores and interpret what the subtype is from those scores?
That's a really interesting question. We've done some market research, and honestly, physicians, different physicians prefer different things. My own personal bent is it's always better to provide a little extra data in these critically ill patients. So I think probably what would make sense is providing continuous scores together with, some kind of binned readout. But as we move forward, there are a lot of questions about, well, what does it mean to have a score near the decision boundary, and some other things that have been, always questions for all diagnostic tests, but certainly continue to be questions for new modalities as well.
This is an AI-driven test. Can you talk a little about the data that was used to train the system and what was done to validate it, and how many different data points is it considering when viewing a sample?
Sure. So back to TriVerity. TriVerity produces these 3 scores, right? A bacterial score, a viral score, and an illness severity score. And each of those scores is produced by using AI and machine learning to interpret a selection of 29 host immune mRNAs that we measure from peripheral blood. So these 29 mRNA targets were selected from the entire transcriptome. In early work we did at Stanford well over a decade ago, picking out those targets which are most informative for whether or not a patient has an infection, if they have an infection, whether it's bacterial or viral, and then also predicting its severity. And that's how we selected that panel of markers. And then at Inflammatix, we gathered a database of about 20,000 patients from different settings around, the emergency department, hospital ward, or ICU. And this represented well over 50 different clinical settings, different clinical studies. It's actually rounding the corner, nearing 100 different clinical studies. So it's a lot of heterogeneity that are included in that data set. And then we went one step further, which is we had physicians go through by hand each one of those records and determine, does this represent somebody with, an infection, and if so, what kind, and to double check the outcome that they actually experienced. And so that's the training data that we then use to train our AI algorithms that interpret those 29 markers into the 3 bacterial, viral, and severity scores.
And as you mentioned, the system's based on work you did at Stanford University School of Medicine with your Inflammatix co-founder, Professor Khatri. What was that work?
So I was at Stanford training in general surgery. I had done med school, did an MD and a PhD. The PhD was actually in translational mouse models in sepsis. And then came to Stanford to train as a general surgeon. My plan was to go into trauma surgery and critical care. And I did some research with Pravesh, and Pravesh had really been a pioneer in learning how to knit together transcriptomic data sets from different sources to create large, pooled clinical studies. So what I mean by that is, early on, a lot of his work had focused on organ transplant rejection. And so, for instance, he had found that if we put together studies looking at different kinds of solid organ transplant rejection, heart, lung, kidney, liver, he could find really, really repeatable signals by sort of knitting these studies together. And so when I joined Pravesh's lab, it was great. You've developed these great sort of big data tools. Pravesh is a professor of computational immunology, so that's his background is in sort of signal processing and big data. And I said, why don't we apply this in critical illness? And so we worked together to understand, how to pull signal out of the incredible complexity of the acute immune response. And I think in many ways, that's what has turned out to be so deceptively challenging in this space. When we think about most transcriptomic studies, people are pretty familiar with them, or at least maybe, in terms of cancer. That we've used mRNA or gene expression panels in cancer for certainly well over a decade. But people with cancer largely have sort of similar time courses, and there's some consistency of that cancer over time. When you think about somebody coming into the emergency department, they might show up early or late in their process. They might show up critically ill or frankly with the sniffles and be ready to go home. It can be, all extremes of age, of course, all different races, all different comorbidities. Plus, some people, of course, also experience an infection as an inpatient. And so there's this multiple different axes of change. And that was one of the things we really had to overcome, was trying to find a way to knit together a single algorithm that would be highly diagnostic despite that huge heterogeneity of presentation. And so over the years, we've now published almost, I think the last count was over 36 manuscripts talking about these methods and how gene expression can be used for diagnosis. But it's a very hard problem to find something that doesn't fall off a cliff when suddenly, in terms of accuracy, when suddenly you see a new kind of patient. And that's really the goal, is what you want is to produce a test that's stable and accurate across a broad population in order to actually have a serious and substantial clinical benefit.
And at what point did you say there's a company here? Why not just license the IP to a diagnostic developer? What was the reason for launching Inflammatix?
Yeah. Well, actually, we did try to license it. I wasn't sure I was going to leave medical practice to do this. In retrospect, the pitch, not surprisingly, did not find many takers. We would go to major diagnostic companies and say, if you hire a team you don't have in computational biology and machine learning, and you build a test system that doesn't exist, which is to say, we need to be able to measure dozens of mRNAs at once in under 30 minutes, sample to answer. Then, upon doing those things, you can displace your own tests in microbiology, which are currently making you billions of dollars. And sort of not surprisingly, that wasn't a great pitch uh, to those folks. So we decided, look, if, unless somebody's willing to go do this, it's going to stay as a really neat research project. It's not going to benefit anybody. And so we incorporated a company and applied for DARPA funding. And our first funding was from DARPA. We got $1 million from DARPA, and I left residency to go found the company with our third co-founder, Jonathan Romanowski. And that was in 2017 that I went full time. And then since then, obviously, we've had a very different course. But, in the end, someone has to be willing to take that leap of faith that this is worth building for many different reasons. And so that was the early story.
I imagine you could apply the same type of precision diagnostics to other types of infections. Is that the potential here with TriVerity? And are you looking at broader uses beyond sepsis?
Yeah, well, TriVerity is focused, again, not just in sepsis, but really in the broader funnel of patients with suspected infection, where we can, by moving diagnosis into that less severe group, we can case find those patients who are sicker than they look and get them really urgent treatment. But we can also help just keep people, for instance, out of the hospital if they don't need to be there. That's the hope. And certainly there are many applications of just this particular test beyond just the emergency department, right? One can imagine patients showing up at an urgent care or at a skilled nursing facility or other places around the healthcare system where we have suspicion of an infection and want a better diagnostic tool. But there's also this idea of making new tests for just new conditions. And one of them, to your point, is around identifying subtypes of critical illness. That's what we call our endotypes test, where with a different signature, we can identify these subtypes of critical illness that would be separately druggable. And then actually, although we could continue with infections, we see a big opportunity in improving cardiac care. There are a lot of still syndromic presentations of chest pain or, suspected stroke or, possible blood clot in the lung, where better testing could lead to better outcomes. And we think that the inflammatory profile of those patients holds a lot of information that we can bring to bear for better patient outcomes.
Well, as you think about building a broader pipeline, how do you think about the opportunities that Inflammatix is pursuing?
Well, our number one focus right now, with TriVerity having been on the market for about, 8 or 9 months, is just making sure that product is out there and generating clinical evidence and being adopted by health systems. And I'm pleased to say that piece is going very well. We have a number of implementations ongoing, and the early interventional data looks very, very good in terms of the benefits that we can bring both to patients and to the healthcare system. And so that will be, our continued focus over the coming years, is just growing that same revenue base to make a great company. As we continue that and that install base grows of our, we didn't really talk about this, but TriVerity is essentially a razor and blade model, right? There's a reader and then a disposable cartridge. And so as that reader is available in more places, and we have more health system partnerships in place, it becomes easier and easier to do development on new tests. And then as those tests get developed, of course, then you have, a way of sort of a ready base of partners who can, look at implementing the next test in the pipeline. So I think
you're using the same device for different tests to plug in the future?
Exactly. So we have this cartridge that can go from blood to a highly multiplex gene expression signature in 30 minutes, sample to answer, with no intervention from the user. And that's a really special thing. It's actually what I'm pretty sure is the world's highest multiplex, meaning we can measure the most targets, quantitative instrument for blood testing. And to give you a sense, it used to take, if we wanted, when we were developing the test, if we wanted to measure 29 mRNAs quantitatively from a blood sample, it might take us the better part of a day, or sometimes even overnight, to do all the steps of RNA extraction and then multiplex profiling. Today, we do it in 30 minutes. So having established that platform, now all we need to do is change the targets that it measures at the end. And then, of course, it's very easy for us to do new blood tests for new indications without having to build new hardware.
Tim Sweeney, CEO of Inflammatix. Tim, thanks so much for your time today.
Dan, thank you for the opportunity. I really appreciate it.
Thanks for listening. The Bio Report is a production of the Levine Media Group. To automatically download this podcast each week, subscribe to our RSS feed or through iTunes or other podcast manager. To join our mailing list, go to levinemediagroup.com. We'd love to hear from you. If you want to drop us a line or are interested in sponsoring this podcast, send an email to danny@levinemediagroup.com. Special thanks to Jonah Levine, who composed our theme music, and the Jonah Levine Collective, which performs it.